All right, so part 3 in the STEMI series. We're going to do a couple of practice EKGs here. We're going to do about 5 or so on this. I have, like any cardiology instructor, I have a ton of practice EKGs, and I'm thinking about doing some music videos where we can run through maybe 10 or 20 or so at the time, where it's just a confirmation of your diagnosis thing. I would love to talk through all 25 or so of the EKGs on this certain presentation. But I just don't think YouTube would let me upload something that long, and if they did, I don't know how many people would watch it. So let's jump right in. Couple of things to remember when you're practicing with these EKGs. STEMI can involve multiple areas of the heart. So it doesn't have to be just an anterior or an inferior or a lateral or a septal, right? You can have an inferolateral, anterolateral, anteroseptal, different things, all right? Contiguous leads. So just remember that. Real quick rundown of the charting here. So we need to know what leads we're talking about. 1 in AVL or lateral, 2, 3 in AVF or inferior. Anterior is V1 and V2, as well V3 and V4 are anterior, and then your septal wall or your anterior can be V1 and V2. Generally, V1 and V2 are just called septal, and then you have what are referred to as the low laterals in V5 and V6. And there's a little controversy there, but we're not going to jump into it too hard. So let's just go straight to the first EKG. Take your time. If you need to pause this video, go ahead and do so. You do not have to be fast. You have to be right. Nobody ever compliments a paramedic or a nurse or a doctor and says, hey, oh man, they read an EKG so incredibly fast. That is never a compliment you hear paid. You hear them say they read one well. So read it well. Don't read it fast. All right, so probably the first thing that jumped out to you on this one was V2, V3, and V4, and even a little elevation in V1, right? So a large area of infarct. Certainly the left anterior descending is what we would anticipate is infarcted here, and we'll go over that on a chart here in just a second. One thing I do want to draw your attention to is leads 1 in AVL. So there's a little elevation in 1 in AVL, which indicates high lateral involvement. You also have reciprocal depression in 2, 3 in AVF. So the reason I chose this for a practice is you're not wrong to call this an aneroseptal STEMI. You are not wrong to call this a lateral. You can call this either one as long as you recognize that it is both a STEMI and it has anterior involvement, because those are the clinically, the morbidity and mortality attached to that anterior involvement or that high lateral MI is pretty terrible, right? And this is where the term widowmaker comes from. And you guys know I hate that term if you've been following this channel, but if you choose to use it, you're looking at a widowmaker. All right, so moving forward to the chart that we have here. As you can see, the left anterior descending is responsible for perfusing V1, V2, V3, and V4. So we are looking at an occlusion of definitely the left anterior descending as well as some circumflex involvement. So there's a lot going on. This is a very large MI in terms of infarcted myocardium. So we'll move to this next one. Take your time, pause the video if you need to. All right, so what should have jumped out at you? Lead 1 in AVL. So the morphology changes from beat to beat, the ST elevation does, and there could be all kinds of things going wrong. But what you're looking at is a lateral MI. So we see the elevation in 1 in AVL, we move down to 2, 3 in AVF. We have reciprocal depression for sure in 3 in AVF. Not quite as prominent in lead 2, but that's the way the game is played, right? You don't always get beautiful reciprocal depression. But as long as you've got it somewhere and it accompanies that elevation, you can be certain that you're waking the cath lab team up at 3 in the morning for the right reason, okay? Just checking back to the chart here, leads 1 in AVL, usually perfused by the circumflex artery. So we're looking at an occlusion of the circumflex artery more than likely. Big MI, so to speak. As you can see, the circumflex perfuses a large part of the left side of the heart, which is where our left ventricle is. This is where our blood pressure comes from and all those things. So a lot of complications that can come from that one. Let's go to the next EKG. Take your time. And what should have jumped out at you in a big way here were leads 2, 3 in AVF. So huge amounts of elevation there. One and AVL show the requisite amount of reciprocal depression, so we are pretty certain we're dealing with an inferior wall STEMI here. One very noteworthy part of this EKG I like to bring up when I present it is V2. So if you look at V2 and you see this ST segment depression, and if you were to flip that upside down, if you could just flip that wave upside down, that would be ST segment elevation. And the reason it looks like that is there is posterior involvement in this MI. Okay, so if you remember your reciprocal depression charts, they say that lateral MIs have inferior reciprocal depression and inferior MIs have lateral reciprocal depression. But your septal and your anterior MIs don't have reciprocal depression. Well, on a 12 lead, that's true, but it's not entirely true. Wherever there is elevation, there is depression. There is ST segment depression. What you are looking at in V2 is the reciprocal depression from the posterior elevation. So if you were to do a posterior ECG, if you were to put the leads on the back of the patient in lead V2, you would have ST segment elevation. You would have a STEMI. That would show your posterior wall MI. So when you see this, what this means is that you have an occluded right coronary artery in someone who is RCA dominant. So they have a long extension of their right coronary artery that is wrapping around the back of the heart and perfusing the posterior wall, and even that is infarcted in this patient. So when you see this, what makes it noteworthy is this is a large MI. This is a big deal. Not to say that any STEMI is not, but this is a bigger deal than a big deal. So just something for you to be on the lookout for. And we'll go back to the chart here. Right coronary artery perfuses 2-3 in AVF. Circumflex perfuses 1 in AVL. And again, the LAD is responsible for the majority of your precordial leads. All right, so we'll do one more after this. This is a particularly good one. Pause the video if you need to. All right, so this ECG is one of my favorites. One of the biggest reasons is, of course, V1, V2, V3 should have jumped out at you. There's ST segment elevation there. It's the J point elevation that a lot of people miss, and it is one of the more difficult concepts people have, or people have more of a difficult time with that concept sometimes because we want beautiful ST segment elevation. Sometimes it's hard for us to look at a J point and say it's there. The problem is, while this is most commonly missed, okay, or of the STEMIs we see, this one is most commonly missed. It is also one of the deadliest. So anterior MIs or anteroseptal MIs are very poorly tolerated in people. This is one of the reasons for that term I love so much called the widowmaker that people use. So this is one of the reasons you hear the widowmaker thrown out there, because the patients tolerate these MIs so poorly. So this is an occlusion of the left anterior descending. Okay. Another thing that's noteworthy about this ECG is if you look in 2-3 in AVF, while you don't necessarily have ST segment depression, you do have T-wave inversion, which means that the inferior wall of the heart is actually becoming ischemic. This is probably due to strain. It's working very hard to overcome these other problems. So you have multiple areas of the heart affected here, even though you only have ST elevation in a specific section. So this is a great EKG. It's a great teaching tool. If you need to take some time to review your J points, please do. And touching on the reciprocal depression thing, if you were to run a posterior ECG on this person, V1, V2, and V3 would have ST segment depression, because you'd be looking at the STEMI from the other side, figuratively speaking. And again, left anterior descending when we refer to the chart. So let's do one more, and we'll call it a day here. Coming up on 9 minutes or so. All right, so leads 1 in AVL are where your elevation is. Very nice reciprocal depression in 3 in AVF. So this is obviously a high lateral MI, which is usually an occlusion of the left circumflex when you refer to the chart. Interesting thing here, we have ST segment depression in V2, V3, and V1 actually. So this kind of goes back to the upside down STEMI thing. So this would be a person who would be left circumflex dominant. So they're the opposite of the right coronary artery dominant person. And if you kind of think of this in certain ways, if you go over the blood flow in the heart, The two arteries on the side, which are the right coronary artery and the left circumflex, they wrap around and kind of meet in the middle and perfuse the back of the heart. And sometimes the left circumflex moves a little, right of center, and sometimes the right coronary artery moves a little left of center. And anytime that happens, we call that person so and so dominant. So in this particular patient's heart, the left circumflex has wrapped around and it's went a little bit right of center. It's went past the midpoint. So this left circumflex occlusion is causing ST segment depression, or it's causing ST segment elevation in the posterior wall, which we see as ST segment depression in this ECG because we're looking at it from the front. So if you were to put your electrodes on the back of this person, you would see, when you looked at the posterior wall of their heart, you would see ST segment elevation. So again, a left circumflex artery dominant patient, further complicating the matter. It is a larger MI than if it were a simple high lateral, right? There is more ischemia in the heart, which is obviously more dangerous. A person who needs more aggressive therapy, they need PCI, they need an interventional cardiologist, or if you're too far from that or they can't make it, they need a physician to drop, T in case or something along those lines to get that heart back to an area or to a place where it can reperfuse until PCI therapy can be applied. All right, and again, another chart of the arteries and what they perfuse here. I hope you guys have enjoyed this. I'll put together a longer video with lots of practice EKGs because honestly, when you're learning cardiology, if practice is everything. You need to know where to look, but then you need to do it 1,000 times to get really good at it. So I'll throw some of that together for you guys in the coming days. I hope you're still enjoying these. If you have something specific you want to learn, if you disagree, if you want to argue, all that's great. Put it in the comments or send me an email at Shade Tree Cardiology if you don't want to put yourself out there. I totally understand that. ShadeTreeCardiology@gmail.com. Look forward to hearing from you. Look forward to filling your request. And as always, guys, thanks for watching. I appreciate it.